Hello, my name's Terry Rudd. I was asked to put on my YouTube channel information about the heart and hemodynamics and cardiac output. So I thought I would go ahead and do that so that you have it as a reference if you need it. So basically, this is the heart. I like to draw the heart with two different sides because the right side and the left side of the heart have very, very different functions. So as you probably know, deoxygenated blood returns to the right side of the heart via the superior vena cava to the right atrium and also from the inferior vena cava. Now there's a third area that a lot of times people don't know about, and it's actually a structure in the right atrium, and that structure is called the coronary sinus. The coronary sinus returns the blood from the coronary arteries, which then go to arterioles and coronary veins, and it returns to the coronary sinus. So three areas return deoxygenated blood to the right atrium: coronary sinus, superior vena cava, and inferior vena cava. And interestingly enough, that coronary sinus has been a place of intervention where they do something called synchronization therapy, where they actually put in a pacemaker wire so that both ventricles can depolarize and then contract together. So from there, we go to the mitral valve, to the right ventricle, to the pulmonic valve, to the pulmonary artery. An artery is a vessel carrying blood away from the heart. So the pulmonary artery is therefore the only artery in the body that carries deoxygenated blood. From the pulmonary artery, we go to 5 pulmonary arterioles, 5 major pulmonary arterioles. And if I were in a classroom situation, I would ask you why. And the answer would be that there are 5 lobes of the lungs, 3 on the right and 2 on the left. Those pulmonary arterioles go to millions of capillaries, and each capillary passes or hugs an alveolus. So we have an alveolar capillary membrane. At that alveolar capillary membrane is where the exchange of gases occur in and out of the lungs. So we exhale, and I would then ask you, what do we exhale? And I know you're probably going to tell me CO2, which is true. But if all we exhaled was CO2, for mouth to sort of work, you would have to be a tree. So in a sense, we also exhale oxygen, 16 to 17%, and then we exhale truckloads of water. I like to say that if we had a convention of chronic lung patients, it would be a very humid convention. And try to remember that anytime you have a patient hyperventilating, they're losing lots of fluid. So then we inhale oxygen, and the oxygen we inhale on Earth is room air, and that's 21%. On Earth, we can't inhale less than 21% oxygen. That's room air. From there, the oxygen goes from the bronchi to the bronchioles to the alveoli, and at the alveolar capillary membrane, the oxygen jumps onto the hemoglobin of the red blood cell. And on that hemoglobin, we have 4 receptor sites. I like to say that the hemoglobin is like a Volkswagen, a little tiny Volkswagen. We should have 14 of them, and all of those 14 should have 4 passengers. And when they do, your pulse ox will read 98%, because the pulse ox only measures how full available hemoglobin is with a passenger, and the passenger hopefully is oxygen, but it can also be carbon monoxide. From there we go to the pulmonary vein, to the left atrium, to the mitral valve. Oops, sorry, did I say tricuspid valve over here? I hope I did. Tricuspid valve here. We go to the mitral valve, and from the mitral valve, we go to the left ventricle, to the aortic valve, and then to the aorta. Now, this left ventricle has a job and a half, and this is why I like to draw these separate. The right ventricle has very little workload. The left ventricle has a job and a half. So that left ventricle has to literally pump up to the nose and down to the toes. And it has to pump to what we would call systemic vascular resistance. But I'm going to simplify that a little by just talking about the blood pressure. The left ventricle essentially has to pump to blood pressure. Now, let's be generous and say the blood pressure was 110/70, okay? So that left ventricle has to pump the fluid that's in the chamber before contraction. And that fluid in the chamber before contraction is called preload. So preload is fluid in the chamber before contraction, okay? Now, that preload has to pump against resistance. And that resistance is afterload. Now, afterload is the resistance that the preload or fluid has to pump against, and afterload is also fluid. So afterload is forward resistance and it's the preload that has to be pumped out. In the left ventricle, the afterload is reflected as the SVR or systemic vascular resistance. Later on, we'll talk about the right ventricle, and that's going to be pulmonary vascular resistance. Preload is fluid before contraction, and in general, that can be measured by a Swan-Ganz catheter, and we measure that by something called the wedge pressure. It also is somewhat of a reflection of your lab value, the BNP, the brain natriuretic peptide. So let's go to this blood pressure of 110/70. So let's just say this ventricle has to pump to 110/70. You know, more than likely, if you've got a good heart muscle, they're able to pump that preload forward, and the resistance is low enough where it shouldn't be a problem. But realize that left ventricle has to pump up to the nose and down to the toes. Let's just say this blood pressure went to 210/100. Look at the work that that left ventricle has to do, because the heart is only a muscle. What happens is this left ventricle has to get thicker to pump against that resistance. So if I go and lift weights, and I'm lifting 5 pounds and then I go to 10, my muscle is going to thicken or hypertrophy. When the left ventricle hypertrophies, the chamber actually gets smaller. And in a sense, that decreases your preload. Now we're going to talk about something called cardiac output. The formula for cardiac output is heart rate times stroke volume. Heart rate is heart rate. As we know, the adult heart rate is 60 to 100, but for purposes of this formula, they use a 60 to 80. And stroke volume is the amount of blood ejected with each ventricular beat. And in truth, when hearts fail and we have problems, those problems are related to the stroke volume. You have to have a good muscle. You have to have synchrony. You have to have the ability to pump it forward. Now, with their 210/100, this muscle is going to have to hypertrophy and get thicker. The chamber is going to get smaller, and it's not going to fail today or tomorrow. It might be 5 or 6 years from now. But one day your person is going to end up in the emergency room because they couldn't get that fluid forward because the muscle failed. And if you can't get the fluid forward, it goes back and it goes back where it came from. And all symptoms of left-sided failure go to the lungs. Left to the lungs, left to the lungs, left to the lungs. They would get shortness of breath, crackles, and in its worst phase, pulmonary edema. The left ventricle almost always fails first because it has such a job. It has a huge body surface area and it has a huge pressure. The right ventricle, in comparison, pumps to pulmonary artery pressure, which is only 25/10. And it only pumps to the lungs. Big deal. Okay? So the right ventricle only pumps to 25/10. It almost always fails secondarily to the left. So if the right ventricle eventually fails and it can't get fluid forward, then that fluid's going to back up where it came from. Superior vena cava, you're going to get jugular venous distension. Inferior vena cava, which is going to result in peripheral edema. Peripheral edema occurs in things that hang. As a result, with that peripheral edema, it's going to go either to the feet or the hands, but I like to say to the rump. I like to say right-sided failure goes to the rump. Because if this person is not feeling well, they're going to be sitting in a recliner and their feet may actually be elevated. So basically, I'm going to do a little summary here, and then we're going to do a part 2 that talks about the cardiac rhythms. So cardiac output is heart rate and stroke volume. So going with the heart rate times stroke volume, for example, if somebody's dehydrated, you would know that their stroke volume is down, correct? And we know that dehydrated people are tachycardic. And if they increase their heart rate, they're going to be okay. But what happens to our patient who's on 5 cardiac drugs and they're hypoxic or dehydrated, or they have problems with their heart pump? So what's going to happen is, let's just go to the dehydrated. If their stroke volume is down and they're on 5 cardiac drugs, which all affect heart rate and BP, their heart rate couldn't go up if their life depended on it. So as a result, they end up decreasing cardiac output. Conversely, if somebody's stroke volume is shot, if their stroke volume is shot because the pump is poor, okay, what's going to end up happening is the heart rate's going to try to increase, but if the person's not compensatory, they're not going to be able to. Lance Armstrong in his bike riding days, his resting heart rate was actually 34 because his stroke volume was so great, his heart rate could go down and he would be okay. That's going to end part 1, and I'm going to do a part 2. Thank you.